Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise. Glad to have you on board. If you're watching this show live, we're coming to you all these different ways. Be sure to like and subscribe our show. Also, if you're not getting our email, be sure to go ahead and check us out on our MailChimp. Just go ahead and register on our website. Speaking of the website, if you haven't checked this out, be sure to look at uronurse.com. Our website is the best place to go for more information about the show. Also, the best place to go to watch all of our past episodes, and there are 94 of those episodes available to watch anytime you want. Hey, you want to check us out in your car? No problem. Go to our UroNurse Plus area and you can listen to our audio podcast. Every show has an audio podcast made from it. There has been a change. You'll notice that the list of things had something called Google Podcast. That's no longer there. Google pulled that. And Google they own YouTube, so they decided to move it over to YouTube Music. So you can click our YouTube Music, which will bring you to this little thing here. Same exact thing. You'll be able to get all of those audio podcast onlys available through that link. So be sure to join us that way too. Hey, put this on your calendar, June 29th. Yes, we're going to be celebrating our 100th episode, 100 episodes. We're going to have giveaways during that episode, and we hope to have everybody joining us live. The bigger the live audience, the more fun it'll be. We're going to have all of our experts on board. We're going to have guest experts coming on. People are going to hopefully send us some videos that we're going to show. We got all sorts of things planned, and we're going to be doing a giveaway. I call it Have Coffee with UroNurse. I'm giving away $10 MasterCard gift cards with our logo on them. Kind of fancy, right? I'll give away one card for every 10 people that are watching, up to 10 cards. I don't want to be here all day giving away cards. We want to have fun. So be sure to join us for that episode. This week, we're doing something completely different, and it's going to be a viewing party. So I'm trying something new. We'll see how it goes. It's going to be a webcast of a live CME-CE symposium that was held during the North Central Division AUA, North Central Section AUA in 2023. It delves into the latest insights and treatment strategies for overactive bladder. So we'll be doing that in just a moment. And I am going to be the only one here today because it's only just doing a show and the CEs, and it's a longer show. We don't have any of the experts. I'm the only expert here. I will take questions, though, after the show. If there's anybody who sees something during the show that they have a question about, feel free to put those comments in. Of course, let me know you're here, that you're listening. Go ahead and put your location where you're watching us from, all that fun stuff. But we're going to get going on the show right now. Give me a second to pull this up. I have to go to that website, and we're going to play it right from the website. Let's see. It should be right here.
Welcome. I'm Benjamin Brucker from NYU. I'm a urologist that practices FPMRS, and I am a treater of overactive bladder, which is the topic of the discussion today. Here are my disclosures. And I'm joined by excellent mind in the field, quite an incredible clinician, an academician, Dr. Aksa Khan. She's assistant professor and actually the associate program director of the urology residency right here in Phoenix, Arizona at the Mayo Clinic. And here are her disclosures, of which there are none. So this is an educational activity provided by Mededicus and AdMedco. And we're fortunate to have this CME activity supported through an educational grant from Sumitomo Pharma America. Mededicus is accredited to provide continuing medical education for physicians, and this activity is available for one AMA PR, a Category 1 credit. Physicians should only claim credit commensurate with the extent of their participation in the activity. So in support of improving patient care, this activity has been planned and implemented by Mededicus. We know that the AdMedco LLC designation for a maximum of one contact hour, and this is the American Association of Nurse Practitioners recognizing crediting organization. So we have some objectives today. After completing this activity, participants will be better able to identify central nervous system effects of anticholinergic agents used to treat overactive bladder. And we'd also like you to be able to recount findings of clinical trial data on new treatments for overactive bladder. And we'll review some of that. Designed also to give you all appropriate evidence-based treatment strategies for complex patients with overactive bladder. We may talk about things that are off-label investigational. Please refer to official prescribing information for each drug or device discussed in this activity, dosing indications and warnings. We're then going to talk a little bit about the disease state of overactive bladder and really where we are, which will be a bit of a review. I'll try to get Dr. Khan's feedback. And then we have a couple of cases, and the cases will go over more of the atypical patient. And I think as someone that loves treating overactive bladder, it's the atypical patient that's really the fun patient to treat. The straightforward patients are pretty easy. It's the ones that sort of make us scratch our head and say, hey, let's think about this a little more. Dr. Khan will present a case. I have a couple of cases. All right, so the introduction now, we have this condition, overactive bladder, and it's exciting because I think we are, in fact, having more and more therapies become available, new medications, pharmacotherapies, third-line therapies. But we do rely on overactive bladder guidelines to help us sort of shape what we do in our clinical practice. And this guideline is in the process of being updated, but the most recent rendition, the amendment in 2019, does give us this very nice treatment algorithm. And the reason I put the algorithm in is, one, to set the stage and have you realize that we have a history and we get the ability to educate patients, things we'll talk about today. We'll also talk about behavioral therapies a little bit, and then pharmacotherapy management. I think one of the things that we don't necessarily see, and I've used this in many talks that I've given, is really the little intricacies of prescribing medication, the intricacies of how we combine medication or move patients from one medication to another. And I think that hopefully the cases we discuss will let you know that this is certainly a good framework to work off of, but those more complicated patients are certainly ones with which we need to look at the data a little bit more closely, think about the implications of the drugs we're using. And we know that there are obviously therapies when pharmacotherapy is not adequately getting us to our goal, and those third-line therapies, which may also be an expanding pool with some of the newer technologies that are coming out. So in terms of behavioral therapy, I'm going to start, and Dr. Khan, in your practice, who does the behavioral therapy counseling? This is something that I find challenging because I know that it works. We can improve patients' outcomes. 50 to 80% of people will have an improvement in quality of life. Randomized controlled trials show that behavioral therapy outcomes are better than those of medication alone, but it takes time. So how does this happen in your practice?
To be honest, yes, it absolutely takes time. And the easy answer would be to say employ maybe an advanced practice provider to do it. But the patient comes to see you, they've got the symptoms, and you're moving along with the treatment pathway after you've done your basic testing. And it's really a key time to, I think, form the relationship with the patient and form the trust in your involvement and your commitment to them by talking about the behavioral therapies. And especially if you're going to move ahead about talking about medicines or third line therapies, I think we have to cover the first line therapy options as well. So I make a mention of it. I've come up with almost a script that covers some of the big things like bladder irritants, how much volume plays a role, fluid management plays a role. But then at my organization, we also have educational booklets that were created by providers as panels, and I'll give them a booklet. It's got about 30 pages in it that really covers and reinforces the discussion. And I look at them and I say, please read this and see where you can make some changes. The AUA also has some really good resources as well with the My Health and educational pamphlets that you can even give them a website, maybe have a card that's printed and say, please refer to this because it really is important. And I finish by saying that overactive bladder is so multifactorial that there's not one magic cure for it. We have to tackle it from all different approaches, and this is where the behavioral management really is important. And I think that really, that takes me a few minutes to do it, but I think it covers it pretty well.
Yeah, so it sounds like it's lots of different touch points that we need to use in order to have that behavioral therapy. So let's move from our behavioral therapy, which we know can work, may not get everyone to goal, may be a little time intensive, to something that we all do, which is write prescriptions for medication. So there are 6 FDA approved options in terms of the antimuscarinics or anticholinergic medications. There's no real evidence that says one of these medications works better than the other. We know that there are adverse effects of the medications, and we'll talk a little bit more about that, but dry mouth, constipation, and we'll definitely spend a little bit of time talking about the altered mental status, which, if you go to meetings about overactive bladder, is something that's getting more and more sort of traction these days, but don't discredit the dry mouth and constipation because those are real issues. We know that there's safety and tolerability that is favoring extended release formulations versus immediate release. And there are some anticholinergics we think maybe a little bit less CNS toxic, like trospium, darifenacin, and maybe solifenacin, but there are certainly still a lot of things that are not ideal with this class of medication. Contraindications, I didn't really think that this was something that I would see all that much, but we were looking at a big data set the other day, and we were looking at patients that should have gotten a medication, and this was old data, and it actually about 2% of patients didn't get an anticholinergic. It was from the Aqua data set. And I looked up, and the actual incidence of glaucoma in the US population is about 1.5% to 2%. So it actually is out there. And narrow angle glaucoma is something that, again, is a contraindication. We do want to use extreme caution. And I don't know, Aksa, in terms of your patients in Arizona, I know in New York, lots of patients are taking medications now for weight loss that affect gastric emptying. Are you seeing that here in Arizona? Everyone looks so fit when I got to the airport.
No, yeah, maybe at the airport.
Yes.
Absolutely. I mean, constipation is probably the bigger sign for me in terms of just gastric emptying. And how many times am I trying to get in a referral to have people's constipation managed in addition to all of their bladder symptoms, which probably speaks to some similar processes that are happening. But I have to mention it to patients that I am concerned because you've got this already chronically bad issue with your GI system that this could definitely be worsened if we were to start.
Yeah, so really, even our anesthesiologists now are telling us for gastric emptying from medicines like Ozempic, we have to wait longer. And I don't know what the implication is for medications like this. We have caution with medications. There are lots of medications that have anticholinergic properties, and there are a lot of drugs that get metabolized by the CYP2D6, and we'll talk about that a little bit later. But the AUA guideline does say, hey, you need to use these cautiously in frail patients. So there definitely, I think, are lots of data out there that suggests that there are potentially cognitive risks with anticholinergic medication. So let's talk a little bit more about cognitive risk. The SUFU white paper 2022, so hot off the press, really does suggest that if you use anticholinergic medications for greater than 3 months, there is an increased risk of dementia, where short-term use, meaning under four weeks, is typically safe. We always need to weigh the risks of cognitive risk when prescribing medications. I'm not going to stand up here and tell you I don't use anticholinergic medications, but it does make it a little bit of a harder discussion or sort of internal dialogue that I have to have. The white paper from SUFU really suggests that we prefer beta-3 agonists over anticholinergic medications, and it does give us the caution to say, hey, avoid oxybutynin extended release. But I will tell you that one of the most commonly prescribed medications by all of you, and myself included, is going to be oxybutynin IR. And that's not because we necessarily think it's a great drug, but we get told, hey, this is what you should be prescribing for your patient by payers and insurance providers. We know that there are advanced therapies that we should consider getting patients to earlier. And I think that when we look at other societies, there's also this warning. We have an AUA white paper from a few years back that actually says, hey, we as a community need to do a little bit of a better job really encouraging payers, pharmacies, and clinicians to really consider some of the issues that come up with this medication. And I think if you're not familiar with the Beers criteria, this is the Geriatric Society's comments that say, you know what, avoid anticholinergic medications with your older patients. And there are a bunch of different medications and classes of medications listed, but you'll see on the bottom there, antimuscarinic medications, the ones that we prescribe and are told to prescribe, are really highlighted as medications that perhaps we should be avoiding. If we look here, compared to a beta-3 agonist, this was a study out of Canada, a nice large study, about 50,000 people, that looked at the risk of dementia. And it turns out that, yes, patients, if you compare and you match them that are using anticholinergics versus beta-3s, anticholinergics had a higher risk of dementia. You can see that the event rates are thankfully relatively low, but when you think about the number of patients in the US that have overactive bladder, that's what makes this a more scary statistic. This was, I think, a Canadian study, but certainly in the US, we'd see similar, again, statistically significant increased risk of dementia. Patients that were under the age of 75 and male on anticholinergics actually had the highest risk. So if we move on from there and we look, Roger Domachowski put together a nice meta-analysis looking at patients. And the nice thing about the meta-analysis is it takes all this data and all these different signals and noise that's coming in, and it synthesizes it for us. And it gives some statistical power. And I think Dr. Khan in her portion will talk a little bit about this, but you can see that, yes, multiple studies have suggested that there is an increased risk of anticholinergic medications. and the incidence of dementia. So what about beta-3 agonists? It's always, I think, with a lot of excitement and anticipation when we get a new class of drugs, and this is not necessarily such a new class of drugs now, but I think having more options in this class makes it a lot more appealing. And we have two options for a beta-3 agonist, which again, the SUFU would say, hey, use this so you don't have to worry about the cognitive risk. We have mirabegron, which comes in 2 doses. The package insert suggests we start at a low dose of 25 and then titrate up depending on tolerability to 50. And then we have vibegron, which is just a single crushable pill. And I will mention, and we'll talk a little bit more about this, there's no actual blood pressure warning on the label for vibegron, though there is for the mirabegron, the first medication that I mentioned. And then also there's no effect on CYP2D6, which is a liver enzyme that helps digest a lot of medications. In patients with overactive bladder, I think it's somewhere up to 12 medications. 86% of patients with overactive bladder are taking a drug that's metabolized by CYP2D6. So those are some scary thoughts when we start prescribing these medications. And thankfully, we don't need to worry about that with vibegron. So what about the post-approval efficacy data? Aksa, what do you think? Mirabegron came into practice or came into the spotlight, and how do you think it works compared to or versus, let's say, our anticholinergics, which many of us had lots of experience prescribing before we had mirabegron?
I think efficacy-wise, I would say probably just in terms of controlling the overactive bladder symptoms, I would say about even. But in terms of how long my patients are staying on the medications, for sure, 100% people consistently are staying on mirabegron or vibegron. I mean, vibegron's new, but longer. I had to shuffle around through different anticholinergics with patients before, just because the side effects really are the big issue for me.
And which is, I think, exactly what Dr. Khan's seeing. The efficacy looks pretty similar. Certainly suggests that mirabegron 25 may underperform a little bit. Again, it's not a comparative study compared to, but if you're looking at the 50 milligram dose versus solifenacin or tolterodine, pretty similar in terms of changes in the micturition parameters. So we also were talking a little bit before about side effects of medication and patients really not necessarily wanting to stay on medications because of side effects. And it's pretty obvious there's something that's an outlier there, that big spike right in the middle on the left side. And what this is looking at is placebo versus mirabegron versus antimuscarinics. And you can see that dry mouth is really the thing that sticks up. And that's really the outlier to say, hey, these medications can work, but they really can cause side effects. What's also nice to see is that when we look at a new medication like a beta-3 agonist, that compared to placebo, there's really not all that much noise. Mirabegron has led to improvement in quality of life scores in the real world as well. We know that younger individuals, overactive bladder affects their quality of life and actually their work and work productivity. Older individuals that have overactive bladder can reduce caregiver quality of life and chance of institutionalizing a person. So if you think about an older mother at home with a family and she's having incontinence issues, that's a risk factor for her then being institutionalized. And again, not that's necessarily a bad choice, but just think about the implications on your patients. Dr. Khan, in terms of your overactive bladder patients, maybe real world experience, what's the implication, what's the impact that the, I guess, overactive bladder condition has on quality of life?
I mean, it's huge. I mean, I can think of so many examples. I think one example I sometimes will share with other patients, because this is such an embarrassing condition for people. I have a woman who said that she was out gardening one day in her front yard, and she saw her neighbors sit right next to her, and they started heading over to come talk to her. But she said right then she felt an urgency episode occurring, and she was about to start wetting her clothes. She said she didn't know what to do. She just turned the hose on herself and just wet herself entirely, because she was so humiliated about the fact that she was going to be wet in front of her neighbors. I mean, this is real life examples of how much this can impact people, how humiliating it is. I mean, this is aside from the data in terms of how people will socially isolate themselves. They don't go and do activities that they enjoy. Here in Arizona, we have a lot of golfers. We've got people that just, they don't feel comfortable going out and engaging in sports that they like to do because they can't make it to the restroom in time. So obviously the impact is huge, and the prevalence is quite huge.
So let's actually look at some of the data. And if you remember, one of our learning objectives was to allow you guys to reiterate all the data on this slide back verbatim when we're done with the lecture, for those of you that just walked in. No, I'm joking. But let's actually look at it. The Empower study was the main study that sort of led to approval of vibegron. And what you'll see, and what I'll point out, is that the medication actually outperforms placebo. Not a huge surprise, because that's what leads to a drug to get approved. But the thing that I'll call out is you start to see efficacy very quickly and as early as 2 weeks. And it's a little bit bold that they decided to look at this time point, but as early as 2 weeks, you started to see some statistical significant and some clinically meaningful separation in terms of the daily micturitions and the urgency incontinence episodes. And that's for both of the primary endpoints. So we know that superiority of Vibegron versus placebo at 2 weeks is great, but I don't tell my patients to just take the drug for 2 weeks and then stop it, or take it for 2 weeks, and if it's not helping, just you're okay. I tell them to continue to take it for the duration, let's say 6, 8, 12 weeks. And you can see that there's a nice downward slope of the drug. You can also see that tolterodine is the green color. The Vibegron is the one that's outperforming that a little bit lower. And you, again, are having an active comparator just to see where it compares. And even if the efficacy is exactly the same, I think some of those cognitive risks we're talking about and some of the dry mouth side effects are the things that are driving me if I had my choice to choose a beta-3 agonist versus an anticholinergic. But it is nice to make sure that we're not underperforming what our other options are. So as early as 2 weeks. And if we look at secondary endpoints, again, the blue bar sort of outperforming both placebo, and again, not every point is statistically significant compared to the control, or the active control, but that's not the point of the active control. We wanted to prove superiority to placebo, and you have the active control there, but that Vibegron is actually decreasing urgency episodes, decreasing the patients that have incontinence episodes, and increasing the volume per micturition. So mechanism of action is being proven by increasing the volume of micturition. So that's why it's great to see that. And you can see it's actually pretty substantial, about 30 cc's of a reduction or of an increase in volume per micturition. So again, if you think about it, that could be an extra 30, 40, 50 minutes. Maybe that's the patient that Oxa describes, not needing to soak herself with a hose just to prevent having an embarrassing episode. Vibegron adverse events, we do talk about side effects of medication. So if we look at Vibegron versus tolterodine, you can see that if I call your attention to the bold area, hypertension was actually less common in Vibegron than tolterodine, but probably right around where placebo was. And then if we look at BP increase, just two different ways of saying the same thing, but in studies we define them differently. You can see that again, BP increase was not something we worry about. And I didn't stress it before, but there are blood pressure warnings and concerns about the beta-3 mirabegron, which is something that, again, if we're trying to pick an ideal medication to use from pharmacotherapy, something that I think you want to consider. If we look at the extension trial, and this was actually pretty neat, and I do want to ask Oxa if she sees this, but you start to notice things like my patients stay on the medication longer, and then they actually continue to have what they're saying is even more improvement. And I don't think I really saw that. And so when I saw the sort of 52-week extension trial, yes, this is again looking and saying the result is sustained, but what you see is there's actually a continued improvement even out past the 12-week mark. I don't exactly know why, but it is something that's interesting when you clinically see it, but we have a reduction in micturitions and urgency incontinence episodes out to a year. Oxa, do you feel like your patients do stay on the medication longer, stronger? What's sort of your clinical experience with it?
They tend to stay on the beta-3s a year, 2 years. I continue to follow them every year just to make sure they're still doing okay, just because I think historically have seen such a lack of efficacy or a lack of staying on the medicines with anticholinergics. I feel like with the beta-3s, they for sure are staying on longer.
Great. So I think we also have the idea that there are lots of other things we want to look at. In the Empower trial, it allowed us, since it was a big study, to look at patients in certain populations, the older patients where I'm a little more concerned about cognitive risk. And in fact, the medication is as effective in the older patients. What's actually nice is we're not seeing any new safety signals in patients that are, again, over 65 or over 75. And it's a nice study that it included 600, 700 patients over 65 and about 200 patients over 75. Again, if you're concerned about a drug causing a side effect, those are the patients you don't want in the trial. They're in the trial, and thankfully that there's no safety signal. Quality of life outcomes, again, we talked a little bit about this, but if you look at all of these domains, these are things that are really important for patients. And what we see is Vibegron versus placebo, statistically or significantly greater improvements in Vibegron at 12 weeks for coping, concern, sleep, symptom bother scale, and health-related quality of life. So numerically greater improvements as well. And with secondary endpoints, we don't always have the power to show all of them, But certainly this is something that, again, gives us that reassurance that, hey, by treating and improving, let's say, leak episodes, urgency, frequency, we are going to have a bigger impact. So Vibegron versus placebo, if we look at post hoc analysis, minimal influence on cardiovascular parameters, regardless of age. And there was a blood pressure monitoring study that really showed no relevant events, which led to, I think, a little bit of a difference. So I did want to take a moment to highlight some of the differences of the beta-3 agonists. I told you that with the anticholinergics, there may be some little difference in terms of the extended release, not extended release. Maybe some drugs are a little more CNS toxic or not. So if we look and do a similar sort of side-by-side comparison, it's easier because I only have two things to compare here. But the general starting dose, again, we have one dose for Vibegron. Mirabegron has the idea that we need to titrate up, at least according to the package insert, and we can't crush or divide the pill. Didn't think it was an issue, but when you start seeing more and more patients with motility issues from swallowing, or patients with G-tubes, peg tubes, and my daughter actually still can't swallow a pill. And the other night I realized that, and I was like, oh gosh, I never thought about, can you crush a pill? So that gave me a little bit of pause, but thankfully Vibegron we can crush. Renal impairment do not exceed 25 for Mirabegron, but there's really no adjustment for mild to severe. End stage renal disease is the same. We don't want to use these medications. There's no adjustment needed for hepatic impairment. So again, it's a little easier for me to think about it. I don't have to worry about renal and hepatic impairment when mild to moderate in Vibegron. And then we talked a little bit about the drug interaction. The CYP2D6 warning does show up on the Mirabegron package insert, but when we look at Vibegron, there's really no inhibition or inducement of that enzyme. So that actually makes it a lot easier. I don't have to worry about some of the medications that also get metabolized by the liver enzyme. As I mentioned, there's a blood pressure warning for Mirabegron. Periodic blood pressure determinations are recommended, not recommended if severe uncontrolled, so we want to avoid it. And again, in Vibegron, we don't have that. And then finally, angioedema, something that's been reported with Mirabegron, but not Vibegron. Dr. Khan, how often do you hear patients on beta-3s come in complaining of blood pressure issues or concern about blood pressure issues or reading the package insert? I know that my experience is I didn't think they would actually read the package insert, but they do.
Anytime I'm talking about the medication, I do mention with Mirabegron that there's a possible chance that when a small percentage of people that might have blood pressure issues, and I ask all of them to get their blood pressure checked 1 week later and then report that back to us. And I would say, there is definitely a small percentage of people will have a few bumps in their systolic blood pressure, and then we have to have the discussion: do we want to stay on this, or do we need to make adjustments, or what's our plan? I do in our population, we have a lot of elderly patients here in Arizona, a lot of comorbidities. They mentioned the hepatic impairments. We have a very big, heavy liver transplant population here, for example. So some of these concerns absolutely are brought up even before we make the prescription. And so I think we still have to survey and follow them very carefully.
Yeah, so I think Dr. Khan had mentioned this before, but her patients staying on the beta-3 agonist longer than the antimuscarinics, if we're comparing the two. And this nice, I think it was a Chris Chappell paper originally, does show that patients, the discontinuation rate, they still do discontinue overactive bladder medication, but certainly a lower rate. And we know that it's going to be multifactorial. So even having that patient look at a package insert that says, hey, your blood pressure may be uncontrolled or you might have an increase, whether you're seeing it clinically or not, that's a reason a patient may decide, hey, I don't want to keep on the medication, or a patient sort of goes to fill the medication and never actually takes it. There are side effects. We talked about the dry mouth, the constipation, the cognitive issues that do come up. But we know that in general, if patients stay on this therapy and they adhere to the therapy we're prescribing, the patient outcomes are better. That means that your Yelp reviews will be better. Your Google reviews will be better. They're happy the doctor corrected this. But more importantly, from a health standpoint, a health economic standpoint, there are going to be fewer visits to the ER. There are going to be fewer falls at night. And overall, I think if patients stay on the medication, we can do a better job reducing costs. So yeah, that was the first half of what we were talking about, introducing sort of the topics, but we wanted to make it try to come alive a little bit. And I'm happy to have you guys raise hands. There are little cards you can use to reach out if there are things that you come up with. But I think Dr. Khan and I will put together a couple of cases, because the point of this was to talk about some of the more complicated patients. And I'll start with an 82-year-old female with hypertension, diabetes, osteoarthritis, who is now experiencing overactive bladder symptoms. How many of you saw this patient in your clinic? So this 82-year-old female says, I can't go anywhere if I don't know where the bathroom is. She's bathroom mapping. She knows where every bathroom is in New York City. Thankfully, we have a lot of Starbucks. She notes that 3 years of increasing frequency and urgency, voiding approximately 11 times a day, 3 times a night. She's having some rare leaks. She doesn't have any stress incontinence. She feels like her stream is strong. She's emptying her bladder well. She does drink 2 to 3 cups of coffee in the morning, diet soda. I think it's a Diet Coke that she has at lunchtime, and a glass of wine with dinner, a little bit of water sprinkled in there as well. She has high blood pressure, diabetes, osteoarthritis, AFib, and anxiety. This is we'll call it a more atypical case, but as I'm presenting it, I'm like, I have a lot of patients like this, right? This is actually maybe not so atypical, but I want to dive into it. And I think at this point, I'd say, are there things that you're seeing here? And I'll add also, before I ask Dr. Khan, she does have a family history of Alzheimer's disease. So as you're seeing this patient in your clinic, what are some of the things that you're going to almost in your brain highlight to bring up as you start to decide on what therapies we should utilize?
Well, she has hypertension, so I'd want to know how well controlled her hypertension is. Another thing is she does live independently. I don't know how functional she seems, but is she able to take care of herself well? Those are things that are really important.
Yeah, so I think that, yes, I'm thinking those same things. I'm thinking, hey, we talked about some of the behavioral things. We could work on that. But the things that I can't change are her hypertension. She's independently living, and the family history. I'm a little bit concerned about the family history. The allergies, really insignificant here. Medications, metoprolol, amlodipine, duloxetine. So those we were talking about, CYP2D6, and the liver enzyme that metabolizes, let's say, one of the medications that comes to mind. I'm thinking initially beta-3 agonist better for her. We'll get to sort of those questions. But now I'm saying, gosh, do I have a better choice within the beta-3 agonist? She is taking metoprolol, which is metabolized by CYP2D6. So I'm thinking, gosh, maybe a Vibegron is a better selection than a Mirabegron. Her pelvic exam, unremarkable, other than some atrophy, which we'll treat eventually with some vaginal estrogen. Her culture is negative. She has some leukocytes, nothing more to write home about. And her residuals only modestly elevated, about 75 ml. So my question for you, Dr. Khan, is if we're going to be talking to this patient and suggesting, for example, medication and or behavioral therapies, what counseling strategies do you use to try to help improve adherence?
A number of things. I think it's really important, one, to let them know this is going to be a long-term relationship. There's not, like I mentioned, you take a med and you watch a number go down on the screen. This is going to take some time. I'm encouraged by the more rapid onset with Vibegron in terms of response, because many patients, they're miserable. They come in, they want an immediate fix. And I usually used to tell them, I say, we're going to give this a 4 to 6 week trial. I'm here with you. I'm going to follow you along. We're going to make sure that it works. I said, probably within a couple of weeks, you'll start to see some improvements in your symptoms, but we're going to be checking in at 4 to 6 weeks. I do think this gives them some hope, because then they say, all right, like, this person's going to be following me to make sure that this is working. I'm not having the side effects. But again, I am encouraged that with a 2-week onset in terms of improvement, with a rapid improvement in symptoms, that can also give them some more hope as to, like, oh, great, I've got something that can treat this condition.
So the idea of assessing cognitive risk, quickly I'll ask and answer, which is many guidelines and statements say we should be doing more, which is like doing mini mental status exams and assessing for frailty. So yeah, we don't do this, and maybe we should be doing this because there are cognitive issues that do come up. And so really then, how do we end up treating this patient? And Aksa, what would your drug of choice be? And then what's the reality of this?
Yeah, I think just generally in my perfect world, I would not give any anticholinergics anymore. It's not worth it to me. They don't stay on them. They're not happy. And then with the concerns about the dementia, I am honestly concerned about that. With her blood pressure, I think I would be a little concerned about Mirabegron. So if I could get Vibegron coverage for her, it's something that's affordable for her, I think I would definitely lean that way. How do we manage the costs? Which I think that's definitely
so it's
something
tough.
to
I
talk
mean,
about.
I think the answer is there are people in the office that work on it. There are programs that are out there to help your patients get medications cheaper. I'd encourage you to get involved with the AUA and advocacy and talk to your local insurance providers. And again, are we really doing what the insurance company wants us to do to save them money? Or are we doing what we're supposed to because we said we do no harm and we try to help patients? So I don't have an answer to this, but maybe one of the bright minds in the room does have an answer to how we get the medication better covered. But I think that I don't want to be told to use a medication that I'm a little bit concerned may have some side effects in the long run.
And like on my template, I actually have kind of areas filled out where I say, I want to use this medication because, and I do not want to use anticholinergics because, and I list those out and I'll say, their age, I'm concerned about their risk for dementia, their post-void residual is this, whatever it is. And so then when it comes time to submit our documents to insurance, I think it's already listed and highlighted there. I think that moves the prior authorization faster than if you don't do that. And I also talk to patients, say, if we're really set on wanting to use this medicine and we want to work with your insurance, if you could help us out by get the forms and fill out all the basic stuff so that all we really have to fill out is a medical need. We're here with you. We want to get things approved for you that we think are the best for you. I think that also makes it so that the paperwork doesn't sit on somebody's desk for several weeks. It actually will get the paperwork done so that hopefully they can get medications approved that we think would be better for them.
Great points. I'm going to let you take the controls for case 2.
Okay. All right. So this is a 64-year-old gentleman with BPH. For many years, he's not wanted to do anything for a BPH, and now he is having overactive bladder symptoms. So 64-year-old gentleman, his chief complaint is that I'm running to the bathroom every hour and I'm getting no sleep. He's had symptoms for 10 years. In the last 5 years, it's been worsening. He was seen by his primary care and a urologist, and back then he deferred any therapies. Medical history is a diabetic with medium control, hypertension, hyperlipidemia, obesity. I think to your point, this is just almost the norm now. He's had a cholecystectomy, former smoker in the past. He is a driver for FedEx, still working actively. And to get some information on him, he has an AUA symptom score. It's 21, so quite high. And if you look at the breakdown, the symptoms that are happening most commonly for him are frequency, urgency, and nocturia. So more of the storage symptoms. Exam is overall pretty unremarkable, probably a little bit of BPH happening. Urinalysis is negative. Creatinine is 1.1. We get a uroflow and a post-void residual measurement. His Qmax is slightly blunted at 9 milliliters per second. The flow is flat and prolonged, and he has a PVR of 180 milliliters. A few other points, he does also drink coffee in the morning, a couple of beers. He drinks beers a couple times during the week. And of all of the symptoms, the one that is absolutely killing him and bothering him the most is his nocturia, getting him up 3 to 4 times a night. Additionally, he's not as bothered by the daytime symptoms, but it does affect his daytime because of how many times he has to stop to use the restroom while making deliveries. In the past, he's not sure as to what they did to test him before, but they did offer him medicines that he said would affect his orgasm, and because of that, he wasn't interested at the time and just says, it's gotten to a point I can't live like this any longer. So in this gentleman, I moved to urodynamics. I think because of the mixed picture in terms of his symptoms and the residual being, I think, veering to the point where I think we need to assess for obstruction. On the urodynamics, you can see he has these kind of large, high pressure, almost phasic involuntary detrusor contractions. And when it came time to void, he had a high pressure, low flow void. The argument could be made that the pressure was high because it was the terminal involuntary detrusor contraction that then led to voiding, but he didn't have a great flow rate, and his bladder outlet obstruction index did measure 49, consistent with obstruction. So tricky. I mean, he's got a horrible bladder, very overactive, really high pressure spasms, and on his urodynamics, he leaked. To me, and I don't know, Dr. Brucker, if you weigh on it, if a man has BPH, but he's still leaking through that, it really concerns me about not being very aggressive about bladder management. How does that impact you?
Yeah, I mean, I think the urodynamics here, I agree. I would have done a urodynamics. I don't think it's wrong to have tried some, let's say, BPH medication and then done a urodynamics after. But this helps me counsel him to say you might need therapy. I will sometimes, even if I say, look, ultimately we're going to need to treat your outlet, still start the BPH, the OAB medication, because if he has a nice response, then at least it gives me a little bit reassurance that when I TURP him, laser him, aquajet him, whatever I do, he's not going to have as likely a chance of incontinence afterward or urgency incontinence. So I like how you use the urodynamics, and I think I would use it, be aggressive, treating the medication, make sure he's tolerating it. And then ultimately, I think he's going to need an outlet reduction procedure if he does fit obstruction criteria. This patient, I think, does.
Yeah, and I think for me, it was really helpful because you have to go back to the chief complaint. Like, what is making him miserable? He's miserable with his storage symptoms. He hates his urgency. He hates his frequency. He hates his nocturia. And I think we have a really nice example as to reasons he's having that. And I think if we missed managing that in this patient, you're going to have a patient that takes a lot longer to get him satisfied. BPH meds, how long do you give before you wait to see if they've worked in terms of improving his emptying? And then how long does it take for the OAB component to turn around? So I think with this gentleman, we had a nice long talk about some of the conservative therapies. How can you manage, you got to abandon the coffee and try your best to limit your alcohol, all of those things. But we started him on dual therapy with both tamsulosin and overactive bladder medication at the time. He couldn't afford any of the other medicines. We had no choice because of his insurance, so we did start him on oxybutynin 5 extended release. Yeah. So I don't think you're wronged by starting with medicines. I think the reality of the situation is that urodynamics are not quite the easiest to just go ahead and order. It takes a big toll on the office. It's not the easiest for the patient. And the patient has never ever been tried on medicine. So it would be reasonable to start, but I think you just have to, again, continue to reassure the patient, I'm in this with you. This might take us some time to get to our desired goals. So what do we know about using medications in men with BPH? The European Association of Urology did come out with guidelines this last year on the non-neurogenic male LUTs. They mentioned that their beta-3 agonists do show significant efficacy in treating overactive bladder symptoms. Many studies are done in the female population, but they do make a recommendation in men that beta-3 agonists can be used in men who have moderate to severe LUTs that mainly have storage symptoms. So similar to this gentleman here. When looking at doing dual therapy, adding on a beta-3 agonist in patients on medicines for tamsulosin, this is a meta-analysis looking at 3 studies on male patients that were taking tamsulosin, randomized to either placebo versus mirabegron. And what they do find on the forest plots is that there was significant improvement with regards to mean number of micturitions per day, urgency episodes per day, or the total overactive bladder symptom score on the gentlemen that were also started on mirabegron in addition to their tamsulosin. When looking at the side effects, there was not really any drastic difference between the 2 groups, so it really didn't increase the side effects by adding on the mirabegron. And the authors did conclude that there was a slight increase in the PVR in the mirabegron group. It was about 21 milliliters for this study, so overall pretty negligible. So I think the take-home point is that if you have a gentleman with BPH and he's on BPH medications, it's probably safe to add on a beta-3 agonist medication without really any significant side effects, and probably some increased benefit in terms of their symptom response. What about bibegron? This is data that was just released within the last couple of weeks from a phase 3 study, looking at about 1,100 men with OAB symptoms. This was a study completed over 6 months. At 12 months, the study did meet its co-primary endpoints with a reduction in daily micturitions and urgency episodes. And also the secondary endpoints were also met with decreases in nocturia, urgency incontinence episodes, improvement in IPSS scores, and increased average volume per micturition. So bibegron also efficacious and safe in the BPH population, and there was no new safety signals compared to other OAB studies. So going back to this gentleman, I always do a 6-week follow-up with patients because it takes some time for them to get the medications, to get them started, to get into the hang of things. I followed up with him at 6 weeks and subjectively still voiding a lot every 1 to 2 hours with urgency, but his nocturia had improved to about 2 times a night. So a slight improvement on that end, but he was having intolerable dry mouth with medication. This is a patient that you can literally hear the tongue sticking to the top of their mouth when they come in. It makes you wonder if it's even worth it for them to be on it. They've got like this big jug of water because they're just trying to manage their dry mouth. His AUA symptom score, slight improvement from 21 to 19, and his Uroflow PVR, slight improvement in his Qmax from 9 to 12, and his PVR was down to 105. So, Dr. Brucker, at this point, would you say you're happy with this gentleman's treatment? Like we're good now, or would you consider doing something different?
Well, I think you nailed it by getting him better quicker, right? So now he's more willing to try different things. Maybe at this point, switching to a beta-3 agonist is going to improve his adherence and cut out some of the side effects that are bothering him.
Yeah.
And I think it's also reasonable if he's tolerating the dry mouth and you wanted to add a beta-3 agonist, see if he gets better. I think that's reasonable. And again, I think you've seen an improvement. There's still potentially room for more improvement, but I think you're right. Get him better quicker, and then you can sort of fine tune after that.
So when do you actually switch an overactive bladder medication rather than do dual therapy?
Right. So I would switch if he was having side effects. I would switch if he had no efficacy. If the guy was doing pretty well, but just not at goal, and you didn't tell me he had a dry mouth, but I'm not quite happy, I might add a dual therapy. I might even consider in a guy that, let's say, had obstruction, if he's not better, then move forward and treat the outlet at some point before adding 2 therapies for the bladder plus a medication for the prostate, et cetera, et cetera.
Yeah. I mean, I think it's depressing for patients to all of a sudden be on 3 different medications. So I think dual therapy for me, I like to do that as a last resort. I would almost be, I think to your point, should we really work up your prostate a little bit more and see what outlet procedures might be of benefit now that we is going for your bladder? I think that would probably be where I would actually say, let's get a truss and measure your prostate volume now and discuss some different options on that end. because especially with all of the side effects, and now we're talking about drug metabolisms, and I'll be honest, patients come in with laundry lists of medications, and if were it not for sometimes the computer notifications as to some of the drug interactions, sometimes you're writing things so quickly, you don't know if you're going to be impacting some of their other drug therapies. So I think for me, I would probably say, hey, look, if we can find a way to switch you just so that you don't have this horrible dry mouth, maybe we try to switch your medication and then work your prostate up a little bit more. Do you think the AUA symptom score impacts you at all?
I think it does. It allows me to follow the patient and see if we're making progress. So I do like it. We have one more case, 57-year-old male with Parkinson's disease who now has overactive bladder symptoms, having a hard time controlling his urination, Parkinson's for 3 years. He's having multiple leaks a day, 4 to 5 leaks a day, frequency and nocturia pretty substantial. Sometimes has a slow stream, has cut back on bladder irritants, already done the behavioral things, doesn't drink fluid while traveling, and he tried an alpha blocker for frequency and was given oxybutynin by a neurologist when his Parkinson's disease was diagnosed, but did not tolerate it. He's had foot surgery, he's married, 2 children, tremor, depression, medications for Parkinson's and atorvastatin, the classic Parkinson's type features, flat facial features, modest tremor, shuffle gait, and his prostate is benign and small. He does a uroflow. Of course, it's a low voided volume, so it's a little harder for us to interpret, but his max flow rate seems okay in spite of that, and he's emptying reasonably well. If we look here, retrospective data, Parkinson's and patients that are treated with mirabegron beta-3 agonists, many of these patients have failed anticholinergic medication, and what you realize is mirabegron is safe and effective in this patient population. So I think we think that these medications are probably good in these more difficult patients that may have a predisposition to bladder emptying issues, or perhaps they're a little more susceptible to cholinergic side effects. But it's always nice when we have some studies that say about half the patients had an improvement, maybe not as profound as in the idiopathic population, but certainly I think very reassuring. The other thing that I think we talk a little bit about, just to introduce third line therapies, because we talked a lot about pharmacotherapies, but we can in fact use Botox in patients with Parkinson's disease. And again, what you expect to see is the improvement may not be as profound as the idiopathic man that you treat with Botox, but certainly that can improve their symptoms. Higher pre-op PVR was the predictor of treatment failure and postoperative urinary retention. And this was some work that Greg Ventura, one of our medical students at the time, put together. So I'll quickly ask, and in considering third line patients, what are the considerations for this guy in terms of neuromodulation, PTNS, and Botox? Maybe just take a minute and give us an answer on that.
I think you have to do your due diligence. You have to try the meds. The patients with Parkinson's, if we're talking about increased PVRs and now the need to catheterize, that's something really that you need to consider. This is one of my most challenging type of patients to treat. It's a male patient with Parkinson's. You're throwing everything at it. But I think absolutely you have to try the medications first. I don't let them sit in medicines for forever. So 6 weeks follow-up, but by about 3 months, if they're not having some kind of meaningful benefit, we're talking third line therapy options.
Yeah, and we bring them up early. So the take-home points: be wary of CNS side effects of antimuscarinics, especially long-term, and polypharmacy. Hopefully we highlighted that. Beta-3 agonists are effective with a decisive difference regarding comorbidities and drug delivery in terms of the different agents we can choose from. Beta-3 agonists are effective with prostate medication for patients that have BPH and overactive bladder. Don't forget that there are a lot of patients out there that have that. Third line therapies are, again, also effective. We didn't talk too much about that, but you'll have to come back next year for another talk on that. And then have a workflow in place. And I think that Dr. Khan was alluding to, we'll try to work with the patient to try to get the prior authorization. There are pharma companies that are very interested in getting your patient's medication. There are samples, there are savings programs, et cetera. But these can be complicated patients. I think we need to educate patients on overactive bladder and dementia. I think that the medication warnings that go out to patients are really effective. And once they start to realize this, we see more and more of it. I'd like to really thank Sumitomo Pharma America for sponsoring this grant, and Mededicus for putting on a great program. And most importantly, all of you guys for your attention and participation. You can claim participation, claim your credit now. And then also want to thank Dr. Khan for taking time away from her busy practice, her family, her life. I know I always learn a lot and really get a kick out of presenting with her as well. So thank you guys all very much.
Thank you so much.
All right, here we go. We made it. We got it through this talk. Welcome, Lori. Got you back on the screen here.
Sorry, I'm late. I had some computer issues.
I figured something came up.
Yeah.
What'd you think?
I thought it was
Any?
good.
Yeah,
I often wonder through that talk. We do the dual therapy and everything, but I wonder about patients who have Foley catheters or who have stents, and we kind of give them that short term,
yeah.
anticholinergic, whether the mirabegron or the vibegon is beneficial in those patients as well, or is it more of it's not going to work as quickly? Curious about that.
Yeah. I'm going to actually play a little clip on how you can go ahead and claim your credits so you can get your contact hour or your CME, and just watch this right now. Now that we've completed our webinar, it's time to go ahead and get your CME or your contact hour. Just go to our uronurse.com area. And as soon as the show ends, I'm going to have this thing made live, but you'll go right down here to watch our 2024 episodes where all our past episodes are found. Here, you'll see that episode if you want to watch it again, but go to this Get CME or CH and click that tab. It's going to bring you right into the website where you can go ahead and get that. Now, mine's showing resume activity because I already set up an account. But yours is going to look more like this, where it'll say start activity, and it's going to ask you about starting or creating a free account. Of course, unless you already have an account. If you don't, just go ahead and click create a free account, enter your information, it'll create the account. Now, once you have your account, you can go back to that same button on the website and click it, and this time it's going to bring you to that same area where you can resume it. First thing it's going to make you do is a pre-assessment. So you'll do your pre-assessment, and then it'll take you over to, you'll hit next, it'll take you to this webcast, and you don't have to watch it again. Here's the trick. Just go through till the end, and it'll bring up the next button. Then you click next, and you'll get your assessment for doing your post-assessment. Once you've completed that, completed the evaluation, you'll be able to get your contact hours. Seems pretty easy. So something new I wanted to try. I think that's one of the things we haven't been doing is giving any contact hours with our talks. And I thought this might be a nice way to introduce that. And just so you know, I did contact the company, and they said that they're more than happy to have us do a watch party. And that's they're on board with it. As long as people watch and do all the requirements, they're good. If you have any questions for us, go ahead and put those in the comment box. Lori will go ahead and bring them up on screen. I know we got limited time because of how long that program was, but we're still always welcome to take questions. We have anything out there, Lori?
Just a couple of comments. The information was great. Slides and speakers were good. I enjoyed it too.
Good. So again, this will be on the website. It's not there yet. After we go off air, I'm going to bring that information up onto our uronurse.com website. So you'll be able to go ahead and click that button and get your CEs. If you have any issues, feel free to use the Ask UroNurse button to send me a UroNurse question. Otherwise, if anybody has any comments, how you liked it, go ahead, put those in the comment area, and we'll be glad to bring those up on screen. I thought it was pretty interesting. I haven't really, I kind of went into semi-retirement, so I don't do everything anymore. So I don't see a lot of patients with overactive bladder. And so I was around for Mirbetric, but not for Gemtesa. So I haven't really seen it. Have you worked with patients on Gemtesa? Have you seen one versus the other better? Same?
So we do actually, we carry samples of both in the office. And I don't know how many of you guys know this, but Mirbetric has finally gone generic. And so samples are going to be no longer available anyway. I think that because Gemtesa samples are still readily available at this point, that I think our physicians will probably gear towards that. I know that Gemtesa is a newer medication as opposed to the Mirbetric. So coverage seemed to be a little bit of an issue with the Gemtesa, but it doesn't seem like it's as challenging as it once used to be. So, and it works just as well. I think if people fail Mirbetric, they're switching to Gemtesa, and getting good results. So
yeah. Would say that makes sense. I had a patient who was supposed to have a resume done, and they didn't stop their blood thinner, so you could have to cancel the case. Well, they were on Gemtesa for some samples, and they said, "Hey, can I get more samples? Because now I got to go another couple of weeks before I can reschedule and get off my blood thinners." And so I brought him a couple boxes from our cabinet, and this guy was like thrilled to death. He says, "This stuff really works." So that's my experience with it. Is at least that patient was, with BPH was having it. So
We have a couple of questions here, Vic.
Sure.
So we have Joanne, who, how prevalent is constipation with OAB?
Yeah, anticholinergics, definitely. I mean, that's one of the big issues. Patients, if it isn't the dry mouth, it's the constipation.
Constipation is the worst. I mean, and you've got people that are already coming in, the elderly who are already constipated, which makes it worse. And sometimes even their urinary issues can resolve just by, curing the constipation. It plays a huge factor in that. Katie said, do you use estrogen?
So that was mentioned. I think that definitely that's one of the things that's commonly overlooked is just treating for the estrogen lack that can cause all those symptoms that that mirror overactive bladder, frequency, urgency. Sometimes I think even like UTI, and even UTI prevention, because if you change the pH of the vagina by estrogenizing it, it's more able to fight off infections. So definitely,
we use a lot of the estrogen cream, especially with overactive bladder. When women come in and get diagnosed with that, we always put them on estrogen cream. Always.
Yeah. And I've been in urology for a long time, and I can tell you that in the beginning, I mean, urologists didn't use estrogens, period. I mean, it was just not done. And then all of a sudden they started to discover the benefits of it. And, we're estrogenizing everyone, that's a candidate for it because it's such a good result.
Right.
All right. I don't see anything else coming up on the comments. Hey, folks, glad that you joined us. And let us know in the comments or send us an email if you like this. Would you like to see this in the future? Especially after you get your contact hour and it really works. That'll be even better. But I am going to put a plug in for next week's talk. So let's bring that in right now. Now that we've completed our webinar, that's not it.
Vic Sinise, RN, and John Lynn, MD, epitomize professionals who harness the potential of social media to create and promote their personal brands. Their strategic use of platforms like YouTube, Facebook, Instagram, Twitter, and LinkedIn allows them to reach a diverse audience and establish themselves as trusted voices in their respective fields. By actively engaging with their followers, participating in discussions, and sharing valuable resources, they foster a sense of community and solidarity within the healthcare community. Join Vic Sinise, RN, and John Lynn, MD, next week on UroNurse.com as they explain how healthcare professionals can effectively utilize social media to promote their expertise and drive change in healthcare.
I think that's going to be really an exciting episode. John has a lot of talent when it comes to the Facebook group stuff that he runs, the Thriving Urology group, and he's going to share his secrets with it. And of course, I've had now a little over a year of running social media for this program and learning all about how you do that. I'm going to share some of my tips and secrets. I think nowadays it's foolish not to utilize social media to promote yourself, even if it's just so people know about your practice, know what you're driving business towards your business, or if you're somebody who likes to get out and do speaking engagements. Being more known makes a big difference. I'm going to be speaking at the September SUNA meeting. So if you want to come and see me live, come to the SUNA meeting. And I'm going to be doing a talk on this type of information about UroNurse and how I see that can be, utilized. And since I was there, they also invited me to do another talk. So I'll be doing 2 talks. So you can see me twice. But because people know who you are, you start getting these invitations to do things. So it's a big plus. And also for those of you that are on the show, don't forget about uropatient.com. If you're a patient, especially, that show follows at 10:30. That'll be coming on today. We're going to be talking about erectile dysfunction drugs, all those drugs that you can use out there. Plus we'll have handouts on every one of them on our website. So check that out at uropatient.com. All right, Lori. Well, happy Memorial Weekend.
You You the same, and everybody have a great weekend. We have
Yeah.
beautiful weather today, but the next 2 days not so good. So I'm gonna enjoy the weather.
Yeah, it's good weather. The noisy cicadas are driving me crazy.
Oh,
But
so
other
I
than
haven't
that,
heard of one, Vic. There has not
oh,
been. I have not even seen one where I
you're
am.
so lucky. They just go on and on and on. So,
Yeah, it's crazy.
but I do have some grandkids coming in from Denver, so I'll be enjoying some time with them, and my grandkids that live local will be in to join us too. So everybody have a great holiday. Stay safe, and we'll see y'all next week.
Bye bye.